And in the US, currently, he's working as a professor and head of the department of the largest NICU that is in Texas, after having worked in the East Coast for quite some time. And he's been author of more than 100 peer-reviewed articles, and he's got too many things to tell. If I start telling you, I need a half an hour at least to introduce. Over to you, Goutham. Thank you very much for joining us.
Thank you, Kishore, and thank you, Prashant, for inviting me, and thank you, Dr. Suresh, for inviting me. I have some slides prepared, but I would like to start by eliciting some questions from everybody on this call to see what the burning questions are that I can help address in this session. So if you can start chatting in your questions, that would be very useful, and that would help me serve the needs of the audience today. As you know, March 10th or 11th, the World Health Organization declared the COVID-19 pandemic. And since then, many countries across the world have been struggling with how to manage this pandemic. And unfortunately, I live in America, where the number of cases and the number of deaths has far exceeded that of other countries, including China. And that's nothing to be proud of. But what we have done in our NICU is, for the past 2 months, we have just been immersed in this COVID-19 contingency planning and preparations. And we have developed a lot of guidelines and policies for clinical practice. We have spent a lot of time supporting our staff and ensuring that we have enough staffing and resources. So I can share any of these things with you. Okay, so one question that came up is any evidence of vertical transmission? And do all outbound babies admitted in NICU have COVID testing done? So before I start answering, I want to share a resource with you, which I think will be very useful. Let me just... Let me share my screen. In March, when we started dealing with this pandemic, one of the things that I found was there was a flood of information coming at us from journals, from news media, from the internet, and from friends through telephone calls and WhatsApp and texting and so on. So it became unmanageable to handle this flood of information that was coming at us. So I created this website called perinatalcovid19.org. It's a free website, and I just want to go over a few things to show you what this has. So this has a feature called NeoClear. And if you click on this, there is a Google document with key articles and resources and key summaries of the findings of those articles that you can quickly review. Again, this is free access. Then if you go to this section called Guidelines, there is a collection of guidelines for patient care from various sources, including the American Academy of Pediatrics, Canadian Pediatric Society, and an article by Dr. Satyan's group, CDC guidelines. And I put up the NNF Kerala and Indian guidelines as well. So please look at this resource. There are a lot of guidelines in here. Then I have also put up a site called Institutional Policies, where specific hospitals and specific healthcare systems have shared their policies. So you can download these and modify them for use in your own institution. And then this feature called Important Publications. I have tried to organize by review articles, transmission methods, vertical transmission to neonates, horizontal transmission to neonates, clinical features, and so on. So a lot of the questions that you might have during this webinar, you will be able to get answered by reviewing this website. So this is the single most useful resource that I can provide to you. So let's take this question about vertical transmission. So I have been able to find these articles that are listed here. So 1, 2, 3, 4, 5, yeah, 5 articles. One of them is a commentary on the article by Kimberlin and Stagnon. So most of the literature that I have been able to find does not suggest that vertical transmission is very common, but it cannot be ruled out because there are a few case reports where newborns were tested on the first day after birth and were found to be positive. And in one case, this Zheng and colleagues from China, they detected IgM antibodies in the baby soon after birth. So this set of articles should lead us to conclude that vertical transmission is possible, but it's not very frequent. And I think as time goes on and people do more detailed studies, we will have more information about vertical transmission. So that was about vertical transmission. Let me scroll back up. So do all outborn babies admitted to the Nicu have COVID testing done? So this is an evolving feature. And initially, when the CDC in the US rolled out its recommendations, they had only 2 categories. One is COVID-19 positive, and then PUI, person under investigation. And of course, when you're a PUI, you could become a COVID-19 positive, or you could be COVID-19 negative after the test results came back. But very quickly, what happened in the US and in other countries is people realized that there was a high frequency of asymptomatic transmission. In other words, there were adults walking around who looked fine, who felt fine, but they were carrying the virus in their system. And because of that, obstetricians and clinicians across the world became worried that they would be treating an asymptomatic person who came in for a heart attack or for a pregnancy. So, and they would be exposed. And I know several cases where a patient came into the emergency room, an adult patient, or a pregnant woman came in to deliver without any COVID symptoms. And later on, they become symptomatic, or later on, they were tested and found to be positive. And in 2 studies from New York, 14% of asymptomatic women were found to be positive. So because of that, in our hospital and in many hospitals in the US, routine testing of every patient getting admitted to the hospital is fast becoming adopted as a practice in order to protect the healthcare workers. The other reason this routine testing has become adopted is it will help reduce the use of personal protective equipment. Because if you cannot tell who's infected and who's not infected based on symptoms, then the safest thing to do would be to just wear your full PPE for every patient interaction, just like we wear non-sterile gloves anytime we draw blood or change a diaper or do suctioning. But if you start doing that, you're going to very quickly use up your N95 masks, your face shields, your gowns and gloves. So testing was very rapidly adopted as a way to reduce the overuse of PPEs, because if you do a test and the patient is negative, then you can reassure people and say, you don't have to wear the full PPE when you interact with this patient. So there were 2 reasons why there was widespread adoption of routine testing of both adult and pediatric and neonatal patients. So the answer to this question about do all outborn babies admitted to the NICU have COVID testing done? In our hospital, we are doing that. So when a baby is admitted from another hospital, a transfer, we do a nasopharyngeal swab. We institute enhanced respiratory precautions. And then when the test comes back negative, we lift the precautions and treat the baby as a normal baby. Now, I'm not so sure that universal surveillance testing of the sort that I described is a good idea and that it necessarily keeps people safe. But the problem is this pandemic has occurred so suddenly and it's evolving so rapidly with so many new publications and so much new knowledge being generated that we have to adapt on the fly. And hopefully, after we have gathered more data and have more evidence, we will be able to come up with a more balanced approach that balances testing, PPE use, and healthcare worker protection. But I don't know what that final version will look like. The big unanswered question with all these testings, especially surveillance testing, is what is the false negative rate? For example, there are experts who say that the false negative rate is 30%, which means the sensitivity may only be 70% for some of the tests done for COVID-19. So if you rely on a negative test, but it's a false negative and the patient is actually infected and you don't know it, and you think the patient is safe to interact with, you could actually be increasing the risk to the healthcare worker. So that's an important variable that has been ignored in a lot of policies that have led to quick universal testing of all patients. So that was a long-winded answer, also describing what we're doing in our institution. So Shashidhar is asking, how has our hospital prepared for COVID? And I have a slide set on leadership and how to manage the staff through a pandemic. I can share the slides with you later. What is your view on breastfeeding and rooming in of mother who is positive and baby? Again, there is no evidence to give us a conclusive answer on what is safe and what is not safe in this situation. In the US, the American Academy of Pediatrics has recommended separation of the mother and baby if the mother is COVID-19 positive, and feeding of expressed breast milk to the baby. But in other countries, the separation of mother and baby is not deemed to be essential. And people are saying it's an option for the mother to wear a mask or even a face shield and then hold the baby and interact with the baby, because the benefits of direct breastfeeding outweigh the risks of transmission. So that's an open-ended question, and I think you should follow the national guidelines from India. Roaming in, again, a lot of the decisions depend on how much space you have to separate mothers and babies, whether you can maintain a 6 feet distance between the mother and baby, and whether you can place a barrier between the mother and baby. So obviously, separating the mother and baby when the mother is not breastfeeding and putting a barrier between the mother and baby and asking the mother to wear a mask will protect the baby. Now, the big concern that I have about rooming in is not in the hospital, but about how to ensure the safety of the baby at home. Because whether you have a positive COVID-19 mother or you think the mother is not positive, but she has not been tested, I think there is a significant risk of horizontal transmission to the baby. And on my website, there are 2 case reports. One is from Houston, from a different hospital in the city where I live, where a baby who was around 2 weeks old was admitted to the hospital, and there was a symptomatic adult in the house. So the baby got infected from an adult in the house and was admitted to the hospital. intubated and ventilated for a few days. Fortunately, that baby survived and did well. And there was another similar case from Iran where a baby, I think the baby in Iran was around a week old, who was admitted to the hospital with horizontal transmission. So I think we have spent a lot of attention trying to figure out how to manage babies in the hospital. But really, the biggest risk for our newborn babies is horizontal transmission at home, either from a known infected adult or an infected adult who is asymptomatic and we don't know about it. So one of the things we are doing in our hospital is when there is a mother who is positive or a father who is positive, we are giving them a big box of masks at discharge and encouraging them to use their masks at home to prevent horizontal transmission to the baby. And I actually think we should be giving masks to every family at discharge because, like I said, asymptomatic adults can transmit infection to babies. So I think every adult ideally should be wearing a mask when interacting with a newborn baby, at least for the first month of life, until we have a better idea of the epidemiology and the risk factors. Why are we giving masks to the families? Why can't they just buy them outside? It's because you cannot buy masks outside anywhere in any of the stores. So you go to every pharmacy in Houston, all the shelves where the masks are stored are empty. And so we didn't want to discharge the families home, and then the family is going around searching for masks. So what we did was we used some philanthropic money that we had, and we found a supplier from China, and we have bought about 9,000 masks, and we're handing out these masks to families. So again, that was a long-winded explanation about outborn babies and breastfeeding. So the burning question for many of us is, should we do routine testing of pregnant women? And right now, I would say around the world, that is the tendency to test. And let me just pull up the slides I have. Give me 1 second. Yeah, let me come back to the slides. Like I said, in New York, 14% of asymptomatic women who were admitted to the hospital had COVID-19. So they came in for pregnancy, but they were found to be COVID-19 in addition to having pregnancy. So because of that, a lot of hospitals in the US are screening women routinely on admission. And if the woman has not been tested or if the test result is pending, we are tending to approach the woman as if she is COVID-19 positive. So that is the trend. Again, I'm not saying that's the correct thing to do, but that is the trend in the US right now. And that is something you might want to consider adopting even in India. Just give me 1 second. Okay, let's go on to the next question. Just lost the chat feature. Okay, there you go. So why and how infants and young children are spared? I don't know the answer. Again, if you go to my website, I have put up a series of articles that describe case series of children and young infants. And all of them consistently show that the frequency of pediatric infections is lower than in adults. And children do not become as sick as adults. Most of them have mild symptoms, if at all. And even when they get admitted to the hospital, they don't become that critically ill in general. Most of them recover and go home. So I don't know why children and infants are less frequently affected and less severely affected. There's a question about perinatal transmission from mother to baby and why is the placenta protective? Again, we don't know the answer to that. I think we have to wait for more science. So one question is, a few neonates are tested positive. Is it postnatal transmission? We have had 3 patients in our NICU, and the NICUs that our doctor staff, where the mother was known to be positive, and we did a COVID test at 24 hours of life in the baby, and that was positive. We repeated the test at 48 hours of life, and the test was negative. So, known positive mother, 24 hours test was positive, but 48 hours test was negative. So, we're struggling how to interpret this and how to explain this. And meanwhile, the babies were asymptomatic. And so we've thought of 2 explanations. One is that the first test was a false positive, perhaps something to do with the way the specimen was obtained, or did it pick up some secretions from the mother, or was it some sort of a lab error that mistakenly caused it to be reported as positive? Then the other possibility is that the second test is a false negative. So the baby has the virus, but the test could not pick up the virus. So we're considering those 2 possibilities. And we are going to test these babies in follow-up to see what happens and if they have any viral RNA detected after, say, 7 to 10 days. So that's a very puzzling observation that we have had, because the lab says the test is quite reliable. Okay, so Rajat is pointing out that the separation decision between breastfeeding and safety of the baby is a shared decision making. I agree with that. Karthik is asking cutoff age for any newborn coming in with respiratory distress. I don't think we can say there is a safe cutoff age, because any patient who comes in with respiratory symptoms during this time could have COVID-19. So Suman is asking, the current threat to newborn health from COVID seems indirect, resulting from indiscriminate C-section, separation from mothers, interruption of breastfeeding, and access to healthcare. I agree with that. I think what Suman is pointing out, that we are practicing what I call knee-jerk medicine, where we see something, we become afraid of it, and we clamp down and put in place a lot of very strict precautions, saying, let's play it safe. And in the process, we could be harming a lot of mothers and babies from this excessive precaution and overabundance of caution. And I think hopefully in the next few months, the pendulum will swing back and we'll have a good balance of supporting families, breastfeeding, and bonding, while also keeping the baby safe. I don't know about indiscriminate C-section, but if the obstetricians are doing a C-section purely for COVID-19, when there are no other indications, I would strongly discourage that, because there is no evidence that C-section protects the baby or helps the mother. So I would do a cesarean section for the standard indications, but not purely for COVID-19. Yes, so Bharati is asking, if a baby is admitted for respiratory distress in the NICU and later on discovered to be COVID positive, how do we deal with this with respect to other infants in the unit and other healthcare personnel? So that is a topic that is a very important topic. because it is a topic of how to handle exposure, both of patients and healthcare workers. And remember that the exposure can come not just from a positive patient who was admitted without us knowing that the patient has COVID-19, but it can also come from a healthcare worker or an adult parent who is positive and may not have symptoms. Now, in all hospitals in the US and in many other countries, they have instituted a strict policy of doing checks at the time of hospital entry. So today, if you want to go into my hospital, you have to answer a questionnaire. They will check your temperature with a thermal camera, and then they will give you a mask so that you can wear a mask before going into the hospital. So because of that, symptomatic adults will probably not be allowed to enter the hospital. But if you look at the data from adult publications, many adults with COVID-19 do not have symptoms. For example, only 40% of the adult patients in Wuhan, China had fever. The rest did not have fever. So it's possible that an adult who is a healthcare worker or a family member will enter the hospital who is asymptomatic but has the virus. So that person can spread the virus to other patients or to other healthcare workers in the hospital. And of course, as Bharati is asking, a baby that we admit who's symptomatic might also be later discovered to be positive, and that baby might expose others, including healthcare workers, to the virus. So when that happens, we immediately have to isolate that baby and put in place what we call enhanced respiratory precautions. And then we have to do tracing of who exactly did that infected person or patient expose. So who were the nurses and doctors that handled that person, or who came into contact with the known positive doctor or nurse? What were the bed locations that the patient was moved around to? And who were the patients in the surrounding area? And what we have started doing is we will test all the exposed people. And for the adults, we will ask them to maintain a diary of their symptoms. And they will be quarantined for 14 days. So they will be asked to self-isolate at home, maintain a diary, and check their temperature twice a day, and not come in close contact with other family members at home. And if the exposure has occurred to a patient, we also test the babies that were exposed. And of course, part of this is also having a disclosure conversation with the family. So we have had to go to families and tell them that their baby was exposed to a COVID-19 positive nurse because she was asymptomatic at the time she was taking care of the baby, but later on turned out to have symptoms and had a positive test. So naturally, parents get very upset, but you have to sit with them and explain the process, explain that their baby will be tested for COVID-19. We will be monitoring the patient very closely for any symptoms. And unfortunately, we will have to restrict visitation, which has already been tightened a lot, until the baby's COVID status has been confirmed. So these are the post-exposure steps that we need to take. Essentially, isolating the exposed people, monitoring their clinical status, testing when appropriate, and having disclosure conversations about the exposure, the risks, and the plan of action. And of course, a lot of these people who are exposed will be negative or will not have symptoms when you follow them up. The biggest risk for us in the NICU from these kind of exposures is that we lose staff. So if we have one infected nurse or one infected doctor who exposes 8 other people, 8 other staff, or if we have one patient who exposes 8 other staff, then all of a sudden all those staff will have to be out of the hospital in quarantine, which makes staffing the NICU very, very challenging. So it's very, very important to take appropriate precautions to ensure that infected people don't enter the hospital, and that you wear appropriate PPE whenever possible, or when the patient status is unknown. So mother with COVID positive, normal delivery versus cesarean delivery. As I said before, do not make a decision about the mode of delivery based on the COVID status. Just use the standard indications for mother or baby. There's a question about the ACE2 receptor. I don't understand. How is it possible when blood doesn't have ACE2 receptor? I don't understand the question, so we'll skip that. Delayed cord clamping. Many guidelines are saying do not do delayed cord clamping, but there are other experts who say since vertical transmission is not likely, delayed cord clamping should be continued. And the minute or so of delayed cord clamping is not going to increase the baby's risk of vertical transmission. And if the excuse me, if the obstetric team is wearing the appropriate protective equipment, then delayed cord clamping should not increase their risk. So personally, I would continue delayed cord clamping, and I would not stop it. So Praveen is asking, what are some of the innovative strategies you have seen to ensure COVID-specific guidelines are followed during resuscitation, transport, and isolation? So let me quickly address that. And again, if you look under guidelines under my website, there are a lot of guidelines about specific things you can do related to resuscitation and transport. For example, there's a guideline in neonatology by Daniel DeLuca and colleagues, and the European guidelines just were published. Essentially, the summary of all those is, as far as possible, the neonatal team should not enter the room if the mother is COVID positive. And if there has to be a neonatal person in the room or a pediatric person, then as few people as necessary should go into the room so that they're not exposed to the mother. If that is not possible, if that is not possible, then there should be a barrier between the mother and the resuscitation team. And also the resuscitation team should stand outside the room as far as possible and go in only at the last minute. So once the baby is born, our team should be wearing full PPE, including N95, face shield, gown, and gloves, and should resuscitate the baby using the standard precautions. Of course, any aerosol generating procedure like suctioning or bagging has a risk of aerosolizing the virus, so we should be extra careful with that. Then when you transport the baby should be transported in an incubator. Ideally, the incubator should be outside the room, and the baby should be taken from the room to the incubator outside the room. And if you have handled the baby and done any aerosol generating procedures, it's better to change all the PPE and put on fresh PPE for the transport, especially if you have to go and press the elevator button and take the baby in an incubator to a different floor or a different building. You should wear PPE that's fresh and that doesn't have the same exposure in the delivery room. And the transport should be done in as sterile a fashion as possible with all appropriate precautions. The baby should be transported in the incubator and then taken to the NICU. And again, the European guidelines on my website have a lot of details about this. You can look at that. So are we seeing more use of telemedicine and other technology? Yes. We have changed our rounding process and our handoff process and our daily morning huddle and morning report and made them all virtual. So previously, every morning at 8 o'clock, we all used to sit in a room and review the admissions from the last 24 hours. Now we just do it virtually using WebEx. So when we do handoff in the evening, we are also doing that virtually using WebEx. So we're trying to minimize face-to-face interaction as much as possible because it's really hard to maintain social distancing in the NICU. Our NICU is not that big. Well, it's big, but it's also crowded. So it's really hard to maintain a 6 feet difference between two people. And so we're trying to do as many things virtually as possible. The one thing that we have not successfully worked out is how to do rounds. We go bed to bed for rounds. And we try to do tabletop rounds where you go to a room and round on the patients using the computer. But then it became very challenging to invite the nurses for the babies and have them participate. So we haven't worked out an ideal process for that. And that's something that we need to do. Suresh is asking, what is the chance of aerosol transmission from a crying baby who's COVID positive? I don't know the risks of that and what are the probabilities of that. But what should be reassuring is it's very rare to have a neonatal patient with a pneumonia who could be like crying virus out into the environment. It's a very infrequent occurrence. But I suppose aerosol transmission can occur if there is a baby with COVID pneumonia and the baby is vigorously crying. One of the concerns about aerosol transmission came from an incident in Los Angeles where there were multiple people who were practicing singing in a church choir. So one of those people had COVID-19, but they didn't know it. But after the choir practice, that person became positive and was detected to have COVID-19. And within a few days, a lot of people in that group also became positive for COVID-19. So the suspicion from that incident is that because of the singing, the positive patient somehow was able to generate aerosols that went through the air and infected the other people in the choir. That's one of the theories. But in general, the prevailing belief is that the prominent method of transmission is through droplets that come out from your nose and mouth and then fall to the ground within 6 feet. Aerosol transmission is thought to be likely, but not very common. And so most of the precautions that are in the literature and from experts are targeted against droplet precautions and not so much against aerosol infection. But if the patient has an aerosol generating procedure or an aerosol generating condition like ventilation, then we assume that the risk is much higher and we put on full protective care for that. So Dr. Dinakar is asking about treatment with heparin if the baby has DIC and ARDS. I don't have any knowledge about that, and there's no evidence to give us any guidelines about that. So I would just use your best clinical judgment. The main treatment for known COVID positive patients is good supportive care, especially in infants and babies. So I would not routinely use heparin, but if you see any evidence of thrombosis, then heparin is an option, and you have to weigh the risks and benefits carefully. What is the false positivity in RT-CPR? I don't know the answer to that. I have not found any articles to tell us that. So that, yeah, Dinakar is also asking, in one study, that's the one by Zeng and colleagues, IgM was positive, but they had PCR negative, which is why there is a lot of questions about vertical transmission, because it doesn't cleanly fit the pattern that we see with vertical transmission in other viruses. So what is the ideal time to test the newborn for COVID-19 born to suspected mother? According to the AAP guidelines and according to our practice, we're doing the first test around 24 hours of life, a nasopharyngeal swab, and we'll repeat the test at 48 hours of life, again, the same nasopharyngeal swab. Do you see H-type and L-type pictures of COVID-19 in units? I don't understand what H-type and L-type is. Maybe Dinakara can explain that. Yeah, validity of PCR, and should we use the likelihood ratio? Yes, absolutely, we should use the likelihood ratio because, like I said, the prevalence of infection in New York was 14% in asymptomatic mothers. But in our hospital, this is the slide that I was going to show you earlier. So I hope you can see my slide. This is a study published in the New England Journal by Sutton and colleagues. 215 women were admitted, 4 were symptomatic, and all were COVID-19 positive. Of 211 asymptomatic mothers, 29, that is 14%, were positive. This was from New York, from 2 hospitals. Then from the same region in another hospital in New York, there was a study published where 116 women were admitted, of which 145 were asymptomatic. And of those 145, they were all tested, 14% again were positive. But this is in New York where the background prevalence of COVID-19 was quite high. In our hospital, only 0.7% of asymptomatic patients, both women and children tested, were positive for COVID-19. So our prevalence is way lower than 14%. So whenever you're trying to test and come up with policies for testing, you have to think of the pre-test probability of the disease, and that will help you interpret a positive test and a negative test using positive and negative likelihood ratios. So absolutely, that's a great question. Let's go back to the question. So we have a lot of questions. I'm glad people are so engaged and interactive. Any drug trials to prevent perinatal transmission? Not that I'm aware of. Serological testing of COVID-19, that is still in evolution. There are a lot of antibody tests being offered and being conducted, but the reliability of those tests today is uncertain. But I think in the next couple of months, we should have reliable antibody tests. There are 3 interesting antibody tests in adults. So in New York and 2 regions in California, they used antibody testing to go test asymptomatic adults who had no history of COVID-19 positivity to see how many people in the population actually had seroconverted from an asymptomatic infection. In New York, 25% of asymptomatic adults who never had a history of COVID-19 infection were positive, 25%. So that's very high. In California, the positivity rate from serologic testing for antibodies was only 2.5 to about 4%. So very low. So again, the positivity rate and the risk to other patients and healthcare workers is going to depend a lot on the background prevalence of the infection in the community. That's an important point I want to emphasize. So how have you been able to deal with the HR distribution, continuing the routine NICU care? I'm assuming the Prashant's question is about staffing the NICU. So what we did was we created a staffing schedule which had 4 layers. So we said everybody has to take extreme precautions to stay healthy. Anybody who's not on clinical service should stay home and isolate themselves and be safe. Hand hygiene, social distancing, 6 feet from other people, wear a mask when you go out, and monitor for symptoms. I also made every faculty member in my section keep a log of the contacts. So I asked them to write down the names of people that they come in contact with every day, so that if they become positive, it's easy to do contact tracing. And then what we created a schedule where we said we have these people on service in the NICU today, but if one of them falls ill, we will ask the first layer of people to come and take their spot. And then we had a second layer of people who would come and take their spot. So we had 4 layers of people, and so that's how we anticipated and planned for HR consistencies. The other thing which we did was we were ready to do remote rounding. So suppose we had very few doctors available to physically be in the hospital, and some doctors were at home under quarantine, but they were feeling fine. So we had decided to do remote rounding where the doctor at home would log in and look at the electronic medical record and do a lot of pre-rounding. So they can look at the intake output, the weight change, the medications, the apnea bradycardia record, the antibiotics, and so on. And the person on site would do the physical exam, talk to the nurses, and do any procedures. But the remote person could also log in and help with the rounding, and they can even prepare the daily note that the on-site person could just sign and modify a little bit. So we had that arrangement set up, but fortunately, most of our doctors were healthy and nurses were healthy. And we were able to manage without pulling in all these contingency plans. The other thing that helped us a little bit was the census of the NICU dropped. Normally, we have about 150 patients in our NICU every day. And in the past 2 months, we've only had about 120 patients every day. So that reduced the burden on our rounding teams. So Naveen is asking about the Indira Gandhi Children's Hospital. It's an outbound unit catering to about 70 units. So outbound units, again, I would say 2 things. One is any baby presenting with sepsis-like symptoms, please consider COVID-19, just like you would consider HSV infection in your sepsis differential. And like I said, in the US, hospitals are routinely screening every outbound patient coming to the NICU for COVID-19 and instituting isolation precautions until the test results come back. But that depends on whether you have testing availability or not. And if you don't have test kits available and you cannot do a lot of tests, then you're left with symptom screening of the attenders of the patient, and then careful clinical monitoring. If you want to be 100% safe and not expose any healthcare workers to any patient with COVID-19, then you should be wearing full PPE for every patient, just like you wear non-sterile gloves when you do suctioning or changing the diaper or drawing blood. But that's going to cause a lot of your PPE to be used up. So there are trade-offs to be made. And I think every unit will have to make an individualized decision based on the availability of tests, the prevalence of infection in the community, and the availability of PPEs in their region. So a couple of people raised their hand. Can we hear their voice and have them ask their questions? Because it feels like I'm talking a lot and everybody else is silent. So Srinath, go ahead and ask your question.
Hi, Dr. Gouwtham.
Go ahead.
It's about the asymptomatic babies. when the babies are born asymptomatic, who takes care of these babies in your unit? Is it a healthy relative, probably preferably less than 50 years old, or is it a nurse in the postnatal ward? And when you, because you are going to isolate these babies from the mother, right?
Yeah.
And will these attenders, healthy relative, will be tested beforehand before we actually give the care for them to take care of these babies?
Yeah, that's a great question. Thank you for asking that. This is something that we're struggling with. So Srinath is asking, can you mute your phone now, Srinath? Srinath is asking, suppose you have a COVID-19 positive mother and you have a healthy baby. Who is going to take care of the baby? How can you guarantee that the adult who is taking care of the baby will not infect the baby? And how do you know that they're not an asymptomatic carrier? We are struggling to come up with a good solution for this. So what we're doing right now is we're doing symptom screening. So either a nurse can take care of the baby in the hospital, or an adult who doesn't have symptoms and who has been screened with the temperature and with a series of questions. And I am pushing our pathology lab to allow routine testing of adult attenders so that the father or the grandmother or the grandfather of the baby can be tested. So when we hand the baby to them at discharge, we have some reassurance that we're handing the baby to a non-infected adult. And I'm hoping that in the next week or two, that we are able to get testing of the attenders so that we can ensure a safe discharge of the baby. Because if the mother is positive and the baby is full term healthy, we're not keeping the baby in the hospital. In China, they would keep these babies in the hospital for 14 days for observation. But we're just discharging them home. And I'm really worried that we are discharging them to unsafe conditions. And I'm trying to get precautions placed. Like I said, one of the precautions that we're encouraging is the use of masks. So we're providing surgical masks when there's a known positive mother. But for everybody else, we're encouraging the use of cloth masks if the mother is negative, just to prevent asymptomatic transmission to the baby. Does anybody else have their hand raised? So Rajat is asking a lot of questions about the respiratory equipment. I will skip that because the guidelines that I've posted on my website have all the details. You can look at that, including the use of HEPA filters for the ambu bag, the T-piece resuscitator, and for ventilators. So there's a question about restriction of visitation. We have really restricted visitation severely in our NICU. And we allow only one person to be in the NICU, and that person cannot change day to day. So either the mother or the father has to come in. And previously we used to allow both to come in, and we don't allow that anymore. I'm not saying that's right, and it's very difficult for families and heartbreaking to see. But our hospital made a decision, and we are just following that. So Dr. Vishwanath is asking, neonate is the only subject to undergo rectal swab. So we're not doing rectal swabs on neonates. Although the virus has been isolated in the fecal material of adult patients and children. Breast milk is not tested in the US anywhere. Chloroquine to the staff, no, I'm not a believer in chloroquine. And there are studies coming out that show harmful effects of chloroquine on, they're causing cardiac arrhythmias, and they can cause vision problems. So I would not recommend chloroquine. How is the risk of transmission from asymptomatic adults and children? That's correct. The risk of transmission from normal breathing is less, and more from droplets from coughing and sneezing. So we are recommending that everybody in society wear a mask, just like they do in China and Japan and Taiwan. So that should also reduce the transmission from asymptomatic adults. Question about routine vaccinations. Yes, we should be continuing routine childhood vaccinations. And there are data to show that in the US, that many parents are now afraid to go to the pediatrician's office. And so the rate of vaccination for other diseases is dropping. And that's a serious concern because we could see a resurgence of like measles in the next few months. Should bathing be done soon after birth? Yes, that's a good idea. Percentage of vertical transmission from COVID to a baby, unknown. Shashidhar is asking a very good question. Considering there is no evidence that any child has affected an adult in the literature, are we generally overreacting? I would say yes. I think the entire field right now, especially in pediatrics and neonatology, is overreacting because we see a few scary stories of adults being admitted to ICUs and the hospitals becoming overwhelmed. And we kind of extrapolate that to our situation and think that we may be in the same boat. And so we're going to extreme measures to take precautions. And that, I think, is an overreaction. And hopefully in the next few months, the pendulum will swing back to a more reasonable understanding of risk, and our practices will be much more balanced. LMA instead of bag and mask, there's no evidence to support or refute that. So can we offer any type of PPE to the newly born infant in the delivery room or OT? I would say no. And I'm going to try and pull up a picture if I still have it. So this is a picture I found from a newspaper article. There is a hospital in Bangkok, Thailand that has come up with face shields for babies. And we in our unit have decided to recommend against using these face shields. So we're saying we should not be using these face shields because we don't know how safe they are. Will it lead to carbon dioxide retention behind the face shield? Will it lead to an increased risk of SIDS? And we don't know how safe these are, and we don't know how protective these are. So I would not recommend these face shields. I don't know if there's any other protective equipment that you're talking about. Observation with PPE is practically very different. Practically difficult. I agree. I think we just have to wipe down the stethoscope really well with a cavicide wipe and make sure it's clean. Lucite box during neonatal resuscitation. So there's a doctor from Taiwan who came up with an aerosol box, and I believe HAL in Bangalore also developed a similar box. So the adult intensivists and pediatric intensivists are using the aerosol box for intubation of patients. But I don't think we need to use that in neonates because A, that box is too big for a neonate. And B, I think with appropriate PPE, we can do the intubation quickly and protect ourselves. So yeah, Dr. Naveen Benkappa is asking about the outborn unit and the 70 babies they get from all over Karnataka. So that's a real challenge, and I think you have to work with the referring doctors. And I also already mentioned the routine screening of outborn babies on admission and taking appropriate precautions when handling these babies until you know that they are negative. I hope that addresses the concerns, Naveen. We don't avoid using CPAP. We do use CPAP, but we have not had any cases with COVID pneumonia in babies, so that has not been a question. We have decided to not use NIPPV. Again, the evidence for that is not very substantial, but we're just trying to play it safe. That could be one of the overreaction phenomena that Shashidhar talked about. I addressed the chloroquine. Yeah, a lot of discussion about the new drug remdesivir based on the new study. We're waiting for the data to be published. And so far, the information we've received is only from the news media and from White House press briefings. So I would want to see the data first before making a decision about remdesivir. And certainly there is no pediatric data. So I personally would not use remdesivir in children or neonates at this point. Kangaroo mother care, like I said, it's a shared decision making based on the risk versus benefit analysis. In the US, we would not recommend that, but I'm not sure that's right for the rest of the world. How about modifying the oxygen hood for aerosol hood? This is a great question from Dr. Asha Venkappa. Yes, that's a good point, Dr. Venkappa. And what we have decided is any baby with COVID-19, born to a COVID-19 positive mother, or any baby that's proven to be positive, will be placed in an incubator. And if that is not available, then we will place an oxy hood over the patient. And that is how we will kind of protect from aerosol generation from the baby. I hope that answers the question. There's a question about age cohort mixing of kids to allow development of herd immunity. I cannot recommend anything specific regarding cohorting or development of herd immunity. Rajat is asking about simulated scenarios. Yes, I think that's a great idea. We have done that too. So we've done simulations related to going to delivery, related to transporting a baby, and related to so the transport within the hospital and transport from one hospital to another. We've also done simulations about how to take a baby for an MRI or to take a baby for a procedure outside the unit. I think it's very important to run the simulations in your hospital. That way you know where the exact problems are and how to protect your staff and other patients when you're transporting these patients. And also you will know the flaws in your system about where to find the PPE, who has the key to the box, and so on. So it's important to identify these vulnerabilities. So I think we've kind of run out of questions. I do have a short slide presentation if we have time. Does anybody want to ask questions verbally?
Hi, Dr. Gouwtham. Srinath here.
Yeah.
Dr. Gouwtham, who attends the deliveries of these suspected mothers in your unit? Is it the fellows or the consultants? And if whoever attends is the same person following this baby for up to 48 hours until the test results comes back to limit the exposure to other doctors?
We have a separate resuscitation team that goes to deliveries.
Mm-hmm.
And then they hand off to the Nicu team. So there are two separate teams. So if they're wearing the full protective equipment, then the handing off should not cause any additional.
Shaila.
But what you are suggesting also makes a lot of sense, that the same people handle the baby from first contact until a confirmed negative test. So that way you minimize the exposure to other staff. One of the things we discussed a lot in the early phases was, should we have dedicated COVID-19 teams and a COVID-19 unit where we put these patients? That's what the adult intensivists did, right? They had about 6 or 8 people who were the COVID doctors, and they had COVID nurses, and they had COVID units. But the problem is, we didn't see a lot of cases. And it was hard for me to say, okay, you 10 people will be the COVID team and you will not have any of the duties. You're just waiting for COVID patients. And they would have had nothing to do because we didn't see a surge of patients. If we saw a surge of patients, then I was going to create a COVID team and a COVID unit. We had areas dedicated to that already. And because of that, we're just managing with the general staff and use of protective equipment. I hope that answers the question.
Yeah, and if a baby is ventilated, can we send respiratory secretions, ET secretions, to test for the COVID along with the nasopharyngeal swab?
Yes, excellent question, and that's a good idea to send respiratory secretions. So, do I recommend BCG vaccine and OPV drops? I would not change the vaccination schedule on babies and infants. I would continue the same schedule as before. Shashidhar is asking, as a believer in evidence-based medicine, when people are relying on news and social media and any evidence, how do you feel? I have been very concerned about this, and I call this knee-jerk medicine, where people are reacting out of fear and anxiety and saying, oh my God, let's take chloroquine, or let's do this, let's do that. And I think we should have the same standards of evidence that we follow in general, even during a crisis, and we should not lower our standards. And if you go to my website, there is a nice article by an author called London and colleagues under the guidelines section. And they talk about why there should not be pandemic exceptionalism. In other words, the standards for science and the rigor of how we evaluate evidence should not change during a crisis, and we should have the same high levels of evidence for adopting interventions during a crisis. So let me ask you people about the psychological effects of the pandemic on the staff and how you're managing that, and your own stress and anxiety and the uncertainty about the future. How is everybody managing that? You can chat in your responses or you can talk.
Goutham, we have created a hotline in Cloud9 for all the staff to call, and we have one psychologist and one psychiatrist available to chat for any staff who have anxieties about their or their families. And most of the calls seems to be coming from the nurses. The doctors have not even called. So traditionally, I think the doctors are very reluctant to seek help. So most of the anxieties seem to be stemming from the nurses, according to our experience. I don't know about others, but that's our experience. Maybe you can share your experience.
Yeah, so I will share some slides. Let me pull them up. But while I do that, other comments, what are other people experiencing in terms of stress, fear, and anxiety, and how you're managing that both in your staff and within yourself?
The other thing is this is not evidence-based. In a lot of the WhatsApp groups, the doctors are very worried whether they'll get the COVID and whether they will die, what happens if they die, and people are sharing 3 scenarios. If you get COVID, you will be separated from your family. if you die, you will be separated from your family forever, and what you should do, what you shouldn't do, and where you should store your passwords for various things in case you die. Those sort of anxieties are expressed in the WhatsApp groups, but the helpline is used only by the nurses.
Yeah, I'm glad you provide that support, Kishore. So this is a slide that summarizes the feelings that healthcare workers have experienced during this pandemic. So what I have been telling people is we are not only dealing with a pandemic, but we're also dealing with a panic-demic. So addressing the panic-demic is as important as addressing the biologic and medical aspects of the virus. So healthcare workers have experienced shock. They feel betrayal, especially if the hospital doesn't provide adequate protective equipment. They feel envy for those who are at home under social isolation and not coming to the hospital. They feel frustrated, they feel fear, and the fear is very, very real. And like we've had doctors doing exactly the same thing where they told their wife, in case something happens to me, I want you to know that all the financial information is in this document. And that way you will have access to my life insurance policy and our retirement savings. And really, the risk for neonatologists is very, very low. But still, they're acting as if they're going to like a war zone because of what we're seeing in the media. So addressing that fear and anxiety is very important for leaders. And one of the things that I did very early on in managing this panic-demic is I said, let us have a daily afternoon Zoom call for our entire neonatology section. So every day between 2 p.m. to 3 p.m. for the last 2 months, we have been having a Zoom call. And up to 70 people, 70, join the call. And we talk about a few things. We give them clinical updates. We say, okay, this is the new guideline. This is the new literature that came out. These are the data about testing in the hospital and how many patients became positive. And that has helped a lot because I have tried to combat the stories that people are getting exposed to on the media and on WhatsApp using data and facts from published evidence. During this time, we also do a lot of kind of emotional support. For example, we read poetry that is inspiring or that kind of leads people to be more courageous. We share, we always end with something called an optimism corner, where we share a optimistic story about people who have been through difficult circumstances and how they came through. One of the most important ways to reassure people is to ensure them that your hospital has adequate protection equipment, PPEs. So that single point itself is very, very reassuring to people to hear that the hospital and their leaders will protect them. So let me pull up some slides to kind of list exactly what we did. Okay, so early on during the pandemic, I decided as the leader of the section that there are 3 priorities. One is protecting healthcare workers. 2, preventing horizontal transmission to neonates and family members, which we talked about. And then managing anxiety and fear, that is the panic-demic. One of the important things to provide during this difficult time, is called psychological safety. Psychological safety is defined as the ability of people to speak up and raise concerns about hazards without fear of retaliation, punishment, or intimidation. And there are classic examples of lack of psychological safety during this time. For example, the doctor in China, Dr. Li Wenliang, was one of the earliest people to point out that there is a cluster of infections and there is an outbreak occurring. But he was shut down by the Chinese government, and eventually he got infected and died. Now he's become a folk hero in China. Then in the US, there have been many instances where doctors and nurses who pointed out that hospitals were not providing them with adequate PPE were threatened by the hospital, and some were even fired. Because hospitals were telling doctors to wear the same N95 mask throughout the day, or use the mask continuously for a week and just clean it in between. And when people pointed out that these practices were not safe, they were threatened by the hospital, and they were told not to talk to anybody, not share this information with anybody. So that is not psychological safety. You have to provide, as a leader, you have to provide a safe space for people to raise their concerns. Then the third example is the Captain Crozier incident. There was a ship belonging to the US Navy, and there was an outbreak of COVID-19 infection amongst the sailors on the ship. The captain tried to get attention from the Navy and said, we need to get these sailors off the ship into quarantine, but they were not responding to his request. So he sent emails to a lot of people to raise the awareness and concern. And then he got fired because of he made too much of a fuss. So he was terminated from his job. Naturally, when he left the ship, all his sailors stood on the ship and clapped for him because they admired his bravery and his courage. So leaders should provide psychological safety. The website that I created was also a way to organize the content and information so that people feel that they have good data and good evidence that they can go to one site and read. One of the things I did as a leader was I was not sure our hospital would have enough PPEs for all the staff, especially if we saw a surge. So I started contacting people across the country and in China, and I bought my own supply of PPE that I would hand out to the staff in case there was a problem in our unit. Because I, as a leader, felt I needed to protect my people and not put them on the front lines without adequate protection. So this is my collection of KN95 masks. This is another brand of mask that I have. Then I have regular face masks. I also bought face shields. And so that was an example where I was, as a leader, I took my responsibility to protect my staff seriously, even if I had to spend my own money for that. It was worth it. Then communication is very important to address emotions. So during a crisis, staff need to feel that there is a leader who's in charge, who knows what they're doing, and who has a plan. So as a leader, internally, you might be scared. Internally, you might not know what's going to happen, but you have to project confidence and appear like you have a plan and you're optimistic about the future, while at the same time acknowledging the unknowns and saying that, yeah, there is a risk and there is a lot of bad things that could happen, but this is how we will deal with it. So the best leaders will be truthful and acknowledge the risks, but will also inspire confidence and reassurance. I mentioned that we have a 2 p.m. call every day. That was the single most useful thing that we did, because when we were told to do social distancing and isolate ourselves at home, it led to a big sense of social disconnection. So having the call ensured that we still felt connected, even though we were physically separate. And I used to emphasize how to stay healthy on those calls, including hand hygiene, social distancing, surface hygiene, not touching your mouth, eyes, and ears. we used to review the guidelines on how to interact with the PUIs. And then we would talk about staffing and resources including PPEs. So addressing those things proactively and explicitly was very reassuring to the staff. Uh, One of the other things I also started doing in March is I said, okay, this pandemic is going to last for 100 days. And I said, let's do a countdown every day. So we started with day 100, day 99, day 98. So right now, today we're on day 59 of the pandemic. So we're counting down, and the end of June is when we have said that the pandemic will be over. Now, that's a completely made up thing. Nobody knows what's going to happen on July 1st, but having the daily countdown provided psychological reassurance to the staff that there was an end in sight and this was not going to prolong interminably forever. I used to send a daily email to all my staff saying, this is the latest guidelines, these are the updates, this is the situation. And in that email, I took a lot of care to format it well so that it appeared that I was in control, that I was not like reactive and too overwhelmed. And I made sure that the punctuation, the grammar and spelling was perfect so that there was a sense of order in my communications. And when people emailed me, I would respond to most of them. Then I have been talking on the phone with each of my faculty members to make sure they're okay. We have about 40 neonatologists. I've been talking to them on the phone just for 15 minutes each to check in with them, to support them, and see if there's anything they need. And during these calls, it became obvious that many of them were struggling because their spouses were non-medical people. And the spouses were becoming very, very anxious. While my doctors had access to good facts and information, the spouses were reading Facebook and Instagram and WhatsApp and just becoming very anxious. So I organized a special Zoom session led by an infectious disease physician to answer the questions of the spouses. So we had about 40 people on that call, and they found it very reassuring to have their questions answered by an expert on infectious diseases. I also talked to regional neonatologists, neonatologists in other NICUs in my city, and said, let's all cooperate, and especially around ventilator shortages, because there was a time when we were really worried about having shortages of ventilators. And our institution was trying to put in place a ventilator triage protocol to decide who would receive a ventilator and who would not in case there is a crisis. So I talked to the neonatologists in the city and I said, let's all work together so that if we have a shortage of ventilators, we can transfer the baby to you and vice versa, so that no baby dies in our unit from lack of a ventilator. So Schanefeld and colleagues actually did interviews of healthcare workers, and they felt that there were 5 things that healthcare workers needed. They wanted to be heard, and they wanted their concerns to be listened to. They wanted to be protected. That means we have to provide adequate PPEs and resources for them. They wanted to be prepared, especially with clinical guidelines and practice parameters. Now in the US, in some hospitals, neonatologists and pediatricians from one specialty were sent to go work in adult ICUs to help take care of adult patients with COVID-19. So when that happens, you can imagine it creates a lot of stress. For example, if you're an endocrinologist and suddenly you're being made to take care of a ventilated adult patient, you'll be scared. So doing some orientation and preparing them for that task is very, very important. Supporting healthcare workers with good resting facilities, food, enough time to sleep and recover, that's very important. And then caring for them and their families is important. The example I gave of the special Zoom call for family members is an example. Then I'll stop after these two slides, and then we'll have more of a discussion. Self-management of anybody in a leadership role is very, very important, because this has been an overwhelming time for all of us. And the uncertainty, the information overload, and the massive amounts of stress and fear in society can be overwhelming. So one of the things that has helped me is I have been leading meditation sessions by Zoom every day for some of my staff and for some friends in the evenings. Making exercise and sleep is very important. Taking enough family time. And strangely, during a time like this, it can be very energizing if you realize that you're really responding to a challenge, stepping up, finding new depths and new strengths in yourself, and ultimately you're serving people as a leader. And that quality of serving others can be very energizing and very uplifting when you think of that. And it's common to point fingers and say this broke down, that broke down, but all these analyses and postmortems should be saved till a later date, until after the pandemic. So let me stop here and see what questions have been chatted in. And if people want to ask questions verbally, please do so.
Hello, Dr. Goutham. Can you hear me?
Yeah, go ahead.
Just had a question regarding this. Is there any age restriction for people working in the hospital?
Yeah, so early on, when we found out about the risk factors from COVID-19, I told my doctors and staff that if you want any special consideration, let me know and we will alter the schedules so that you're not exposed to COVID-19 patients. So the options I had was taking them off the clinical service and having them isolate at home, or they would work in the hospital, but they would not be assigned COVID patients. Third option is they would continue their work as usual. Surprisingly, many of my doctors, and we have some pregnant faculty, they all said, no, we want to continue to work.
But here the government itself has given a direction that people aged over 50 years need not get exposed in most of the places. So any such directions over there?
No official directions, but it's an internal adjustment within a department. Because if 80% of your staff are over 50 years old, who is going to be left to take care of the patient?
Yeah, exactly.
How will you manage that?
Yeah. One last question. The newborns which you are discharging to home, are they being followed up with home follow-up?
The pediatrician follows up the patients with phone calls.
Okay.
And we don't have a good system like in the UK or Australia where home nurses visit the families. But if they could, that would be ideal.
Thank you very much, Dr. Goutham.
Sure. So measures taken to raise morale of staff nurses and postgraduates. I think one of my mistakes has been that I have done a lot for the doctors and nurse practitioners. But unfortunately, the nurses and the respiratory therapists were not that closely involved in these afternoon phone calls, Zoom calls, because they would be on clinical duty in the unit and they were not able to join. So I wish I had done a better job of reaching out to the non-physical staff. So we're trying to correct that. We had a special Zoom call with the respiratory therapists. Gave them a lot of inspiration and a lot of updates about our guidelines and reassured them that we were there to look after them. And so on, Yeah, so one neonatologist passed away in Birmingham. Yes, I know about that. I actually attended the the puja by Zoom of this doctor. The risk is low for us, but it's not zero. But one of the things that we have to accept during this time, which is true for life in general, but more so during a pandemic, that there is always risk for us. We could be going out on the road and be in a car crash. We just don't think about those risks. So there is a lot of literature on the psychology of risk perception and how you manage your fear of risk. That has to be understood and used. That literature. So Dr. Naveen Benkappa is asking a good question about emergency newborn surgery. One of the things in our hospitals is the surgeons have told us to do a COVID test on every baby before surgery. Because if the baby is going to be intubated for anesthesia, that becomes an aerosol generating procedure. And the anesthesiologist will be right there intubating and they don't want to be exposed. So we have started doing testing before non-emergency surgery. But for emergency surgeries, they just have to wear the full PPE and go about it because there's time to do the test. We are getting now where we expect the result to be back in about 3 hours. And I think that will help with a lot of kind of semi-emergency surgeries where you can afford to wait a little while. And you can send the test, and by the time you move the baby to the operating room, back. Yeah, Monica is asking a good question about giving the mother proper PPE. I think I agree with your suggestion to ensure that the mother has proper PPE then rather than to the attendant. But I think you have to make a case-by-case decision about how to safely discharge a baby home. So Rajat is pointing out that doctors curiously have illogical fears, and that's proving difficult to assuage. Yeah, so fear has nothing to do with fact, because we're often afraid of things that we should not be afraid of. And we are often not afraid of things we should be afraid of. So understanding that paradox is important. And again, self-awareness, self-management of emotions, very, very important for all of us during these sessions. And again, having group discussions like this, where we review the data and quantitatively determine what's the magnitude of risk for each of us, is very, very important. I think that can kind of combat some of the illogical fears that we're susceptible to. And I personally find meditation very useful in recognizing when my mind is creating fears out of unnecessary things versus when it is creating fear from a legitimate reason. So meditation personally has been very useful to me. No cases that I'm aware of COVID transfer from newborn baby to staff. I think the risk is very low. I think the biggest risk for us healthcare workers is catching the infection from another adult, either outside the hospital or inside the hospital. So which of the changes that we currently have in our unit do you foresee continuing after the pandemic? Great question again from Shashidhar. We are in the process of planning that because I don't think we're going to go back to how life was before the pandemic. I think we will have to continue social distancing. We will have to use technology to do virtual work whenever possible. And we will have to continue many of the clinical precautions to ensure that healthcare workers are not exposed, either from patients or from other adults. So a lot of the screenings at hospitals will continue. One of the big problems we're facing now is economic loss, because the hospital shut down all elective procedures. and all elective admissions in the last 2 months. So because of that, the hospital revenue has come down a lot, and that has led to pay cuts of nurses, executives, and doctors. So just last week, our hospital told us that we're getting a 10% pay cut. And we had already received a 4% cut in our retirement benefits. So total 14% decrease in our income for at least 6 months, possibly longer. So that is adding to the psychological distress that everybody's feeling, that they're feeling they're at risk when they go to the hospital, that they're in danger, and now that their income is also being diminished. So that's become one of the main things that I'm handling right now. So no Ayurvedic herbal preparations that I can recommend. I'm not aware of any trials. So Ranjan is asking, what's my prediction or intuitive feeling about this pandemic in the world and USA and India generally? How are we doing for time, Kishore and Prashant? Do we have time?
Yes, sir. Yes, sir. We have time. Sir,
Yeah,
Kishore, sir.
I think maybe another 5 minutes will close, Goutham, because the people have started leaving.
Yeah, sure. Yeah, what were you saying, Prashant?
Nothing, sir. You can. There are many questions which already they have put. So and Guru Prasad sir, Ranjan sir, and other also have. If anybody has question, please raise the hand. We will unmute and you can directly ask with Gautam sir.
Yeah, Goutham.
I think
Yeah,
Guru
go ahead.
Prasad and
Good morning, Goutham. A wonderful session.
Thank you.
I think you are, as you rightly shared, you are halfway through the
First
current
column,
pandemic,
right N.
and
So that understanding is easy. Right?
it is very unfortunate. Despite such wonderful resources, United States faced the greatest challenge. So more than 10 lakhs tested positive and 60,000 plus deaths. So when the pandemic fear started in
This is normal
India,
bladder function.
ours is such a huge country, 130 crore people, so that fear was there. It is very surprisingly, so far we have had no major damage. And you are aware that the government has withdrawn the lockdown. Today is the last day. Our concern is tomorrow, most of the country, nearly 50 to 60% of the country, they are they will move out of the house. So I just want, out of your knowledge and how you are tackling it now, what should be the advice? Yeah, I agree with you. As neonatologists, we have very little risk for COVID, but we have personal risk walking around in the road, and we have, even today we are taking grounds. Our concern is we have a lot of chats in our small groups. From tomorrow, everybody starts working like usually. What is your advice for professionals like us? You have answered most of it. And secondly, it is very unfortunate at this point of time, the doctors are attacked again, like in any other scenarios. Many doctors have been manhandled and very badly injured. And though government has passed a lot of regulations, there are a lot of safety issues, concerns. And as Dr. Kishore rightly shared, nurses are asked to work in frontline and the doctors stand behind in most of the scenarios. So it is very unfortunate that though we are able to cope up the present workload, we are worried if the crisis is going to be similar in US, how to face it. That is the concern of the entire country.
Yeah, absolutely. Thank you for sharing those, Guru Prasad.
Yeah.
And before I forget, I just want to say how great it is for me to be here with so many old friends and so many colleagues from almost the last 30 years, including some of my teachers. So it's a great privilege for me to be here.
Improvement
So
in
thank you for this opportunity. So I'm sharing a screen now. This is a paper that was published in Science by Kissler and colleagues. And what they did was they did some epidemiologic modeling of what might happen if the restrictions are lifted and if social distancing is stopped. And let me explain this graph a little bit to you. So this is a modeling, it's not an actual study. They took data from China, from Italy, from Spain, And they created a model where they said some portion of the population is susceptible, some is exposed, some is infected, and some is recovered. So susceptible, exposed, infected, and recovered, Sayer model. And this graph shows you on this axis the prevalence per 10,000 population of the infection. That is the black line. Over here is the red line, which is the critical cases for 10,000 population. These are the cases, all these data refer to adult patients, by the way, not to neonates. These are the cases in the red line where the patients need ventilation or ICU admission. The purple blocks refer to the period of social distancing. And if there is no purple, that means social distancing has been lifted. This black line is the, the dotted line is the, is the critical care capacity. Sorry, the black line is the critical care capacity, which is the number of hospital beds and the ventilators available. The dotted line is the threshold at which social distancing is reinstituted. Over here, you see a couple of interesting things. This is the cumulative prevalence of infections. And this is the level in the population at which herd immunity is established. Okay, again, this paper is linked on my website. You can review it. So what this set of authors from Harvard is projecting is that right now we have intense social distancing. And you're going to see a reduction in overall cases as well as critical cases. But once social distancing is lifted, you're going to see a rise in cases again. And when that rise in prevalence exceeds the dotted line, social distancing will be reinstituted again by the government or by policymakers. And the goal is to always remain below the capacity of beds and ventilators and critical care resources. So one option is that in many countries, social distancing and lockdowns will be intermittently imposed based on a rise in prevalence of cases, so that you always have bed capacity and ventilator capacity. And now the social distancing can be of various periods. It can be short with sort of lifting of the social distancing in the summer, or it can be throughout the year, and it can be the length of the social distancing, the period of the social distancing can vary a lot. But these authors project that until July 2022, the pandemic will really not be under control. And it's only when the herd immunity levels are high, as in this panel under C, and when a vaccine is developed, which will also contribute to herd immunity, that the pandemic will really subside. So this is kind of it's a depressing projection, but it's a realistic projection of what might happen, especially in countries like the US, where the number of cases is very, very high. I hope that answers your question, Guru. So, but what we need to do is when the lockdown is lifted or when the precautions are lifted, we need to take all proper precautions to wear a mask when we go outside, hand hygiene, surface hygiene, isolate ourselves from infected individuals or symptomatic individuals, and then proper cough etiquette so that people are not coughing. No more shaking hands. Everybody should do namaste or just bow to people. So we should practice all those things, and hopefully that will protect us.
Thank you. I mean, you made it so wonderfully clear, Goutham. This is precisely the question we are going to ask you. It's here to stay. And the question is, how long more? And you said 2022 June, probably in all optimistic view. That is what you think?
Yeah,
Because
I think the virus will be around in some form or the other for at least a couple of years. And every time the governmental and societal restrictions go down, you're likely to see an increase. Now, one of the things that the Kistler paper projects is, let me share this again. One way to manage this is to increase the number of hospital beds. So if you look at the panels below C and D, the height of the black line is much higher than in panels A and B. So if your society is able to create more hospital capacity and have more hospital beds, then you may feel confident that even if we have a lot of cases, we can treat them and cure them. And so your pressure to put social distancing and lockdowns in place will be less if you have more hospital capacity. Because the big problem with COVID-19 is the speed with which it spreads in society because of a huge unexposed population and the rapid accumulation of cases that overwhelm the healthcare system. That is the biggest risk. And now, like 95% of people who are hospitalized will still survive and go home. But what you don't want is hospitals overwhelmed with a lot of cases, and you don't have beds, you don't have nurses, you don't have ventilators. That will lead to a lot of death. And that's what policymakers are trying to avoid. So be prepared for a 2-year stint.
Goutham,
Go ahead, Raghu.
thank you very much. It was a very interactive session, and it was nice to hear experience right from the horse's mouth.
Oh, thank you so much. Yeah.
And
I can't hear you, Ranjan.
Gautam, thank you. The only concern I have is we are not
Tanzania,
testing
dengue, and other things. Will they now, raise their head? Or vaccine preventable diseases? This is something which sometimes I feel very scared about.
Yeah, vaccine preventable diseases may go up if pediatricians are not proactive in vaccinating children. Other diseases like dengue and seasonal influenza may actually decrease if people are indoors and not getting exposed outdoors to risks or coming in contact with other people. So we don't know.
Gautam, I have one question. In India, the frequency of screening for the population, testing the population is very less. So what do you envisage with the very less kind of testing available, the facilities also, what is likely to happen?
I think if you don't have a lot of testing available, you're left having to screen people using epidemiological risk factors, history, and symptoms. And those are imperfect methods to screen.
Very simple.
So you will have a risk of asymptomatic transmission in the community, which may lead to new cases, but which may also lead to herd immunity. So I don't know how these things will balance each other out, because the best scenario would be to have a high frequency of asymptomatic transmission that leads to seroconversion and a high level of herd immunity so that society is protected. But at this point in time, we don't even know how long the immunity lasts in an infected person. So it's possible that even after infection in a month or two, you could become susceptible. So we don't know. So testing is really, really important. And that's what the Director General of the WHO also said. He said, we have one message for all the countries of the world: testing, testing, testing. So I think all of you, especially those with some policy connections, should really push for aggressive testing, because that's how countries like Taiwan, Hong Kong, and Singapore have attacked these. In South Korea, they test, they do contact tracing, and they isolate. And that way they lock down the infections and restrict them. so that they're not spreading through society.
Dr. Goutham, Serum Institute of India in collaboration with Oxford is hoping to get the first vaccine rolled out in September, as early as September. How about in US? How far they have advanced about the vaccination and how effective these vaccinations will be once they're available?
In the US, they're aiming to generate a vaccine in 18 months, which is very, very fast. Usually it takes 3-4 years to develop a vaccine. So they're worried that they may cause some unintended harm from this rapid attempt to develop a vaccine. And many companies are trying to get into the act and develop a vaccine. We don't know how successful the vaccine will be, how quickly it will be generated, and how quickly they can ramp up production, because you're going to need millions of doses of vaccine. So it's a big question mark. The vaccine is a big question mark.
Sir, I think we will close the session.
Yeah, thank you.
So is there anyone who wants to ask any last questions or suggestion? Kishore sir. We will. It's been almost 2 hours since we've started the discussion, sir. So thank you very much. Would you give any last before you leave? Would you sum up and give in a line a message to all the doctors and health workers? Not about the science; it's about the personal your view on life at this point of time with COVID for all the health workers.
The parting message, I would have 2 parting messages. One is, please use my website. It has the best information available. And the other parting message I have is, again, I put the quote on my website. Let me pull it up real quickly. This is a quotation from Lord of the Rings, where Frodo says, "I wish it need not have happened in my time." And Gandalf says, "So do I. And so do all who live to see such times." But that is not for them to decide. All we have to decide is what to do with the time that is given us. So sometimes we cannot control events. We just have to accept that we are given a certain set of events and circumstances. And during that time, all of us have to rise to the occasion and be leaders and give the best care possible to patients. We have to take care of our colleagues and our families and take care of ourselves. Because this is a challenge and this is an opportunity for all of us to become better individuals and serve society.
Goutham, thank you very much for your wonderful session and accepting our invitation at short notice. And I know it's early morning, so we woke you up, but it was a wonderful session. I sincerely thank you for sparing your time. And I also thank Dinakar for spreading the news so much that we had close to 300 people from all over the world, including Dubai, Muscat, North India, everywhere. So everybody have appreciated. A lot of feedback is coming on the chat, and I sincerely hope we can we can bypass the phase of what the US is facing currently in India. But we look forward to having more sessions with you in future. Thank you very much.
Yeah, thank you for inviting me. Sorry I was not able to say hello individually to all my friends on the call. And namaste, and stay well, everybody. I'm happy to come back.
Yeah, thank you. So we're going to have like this session in coming up. You can log into United National Forum, National United Forum Karnataka chapter. This is for the information which we have privately sent, or Facebook page, or we have YouTube channel as well. It is NNF, National United Forum Karnataka chapter. If you type, you will get it. You can live stream all the sessions we are doing on Tuesdays, Saturdays, Thursday, Saturday and Sunday. So thank you very much, sir. Thank you all the participants. Thanks on behalf of NNF Karnataka. Thank you. Thank you, sir. Thanks a lot, Goutham, sir. Thank you, sir. Thank you, sir.